So everyone, I'll give your hands into Dr. Lin too. So please join.
Thank you, Dr. Dan. It's lovely to see you again. And hello online to my colleagues in Thailand. And good afternoon. So thank you for having me. And with the time we have, I'd like to show some of the basic knowledge of what the light walker can offer in terms of part of the solution for snoring as a part of the bigger problem that is sleep and sleep apnea. So we would, as we go along later, don't hesitate to leave me any questions. I'm happy to stay as long as you need. If you got any question or anything you're not clear during my presentation, you can definitely type in, and Dr. Dan will go through all of that at the end. So a second, we just go back. So here we are. So you can all see my slide there.
Yeah, definitely yes. Yeah.
Okay, that's good. All right, so it's a privilege to sit here and share some information, especially if in the crowd you haven't had Fotona laser before. It's quite unique. And I often speak out there simply because I'm loving it. And one of the things that we do from quite a bit of work is got to look after a patient with sleep, with TMD pain. And that was, and also facial aesthetic. That's why I got laser in the first place. And so let's go. It doesn't, let me second. Doesn't seem to move. Okay. So I'm a general practitioner in Canberra, graduate 29 years ago, and I work in Canberra about 26 years. In overall, yes, like I said, TMD pain, endodontics, sleep medicine, and dental facial aesthetic was what I'd love to do. And the journey I pretty much grow with the patient as they get better, healthier. They looking for some more option to improve, be their look, be their well-being. And so I find that I've got the need to continue learning. The disclaimer is a request of Dental Board that I declare I have no financial interest in Fotona or its product or procedure, and I speak from my personal experience. I have full consent of my patient for using of their image for purpose education, social media, but if you wish to post any of photos, please choose the one with that identity being blocked out, or please let me know beforehand, and it shouldn't be a problem. And so this is what I work every day. I have two light walkers and a dedicated kill switch, a star walker, fully dedicated face and body laser, the Dynamics, and also the latest addition was July a year and a half ago that we have this magnetic chair, and we originally get it as part of the aesthetic solution, but also for pain relief. We use that a fair bit for outpatient. So when you Google this day, if you just ask, what is the top 5 trends in future dentistry, you find laser there. If you ask what is the top 5 technological innovation in dentistry, laser dentistry in the top 5. And even ChatGPT, it put laser there as one of the 5 trend in modern dentistry. So if you haven't been on this journey yet, it's time to get on before we miss the boat. Yeah, because it's really fun. It gives a better solution for our patient. Patient heal a lot faster, and it opens so much more window. Even though I dare say that it will never completely replace the drill, but it's getting more and more application, and we more pleased with development research every day, especially involved with Fotona Laser and the company itself. And so just a brief note, what is laser? Light amplifies, stimulate emission of radiation. The type of light we have the whole spectrum. We have from gamma rays all the way to microwave, radio wave, things you heard of. In dentistry, we're very familiar with UV ray, X-ray more so, and all the visible color that we're talking about, just the color you've seen in the rainbow. In there, we have the red laser, the blue laser we've been familiar with, and near infrared, we have a range of diode, yeah, and also now that we involve it with the ND-YAG, which is 1064, and the YAG, which is 2940 nanometer wavelength. And so as light interacts, go through in the air, interact with surrounding environment, be it water, hard object, everything. So lights bounce, reflect, refract, disperse, and it will give us a beautiful, the color of light. We put it that way. And if we talk about laser light, and Mario Bertolotti said it very nicely, that light, you talked about is light of a laser differ from that of an ordinary light source, more or less like a sound differ from a noise. Yeah. And so it's true. So when we talk about laser, there's special characteristic, like one color, one wavelength, coherent, so that they travel in the same phase together. And they all collimate. So travel together, they have the same amplitude, the same speed, yeah, and the same wavelength. So we're very well organized, and they bring energy with it. So how does energy laser get generated? In an atom, we got the nucleus, we got which is neutrons and protons, sorry, and the electrons circulating around the cell. If these electrons get excited, they will then jump up to the next shelf and the next shelf. All right. But they don't stay excited forever. At some point, they will return to their original position. And as they go from the top shelf down to return one more layer and more, and as it drop in that shell level, it will release energy, and that's photon. And that's what we use for laser. So in the medium that we generate laser, it could be solid state, like a Fotona laser with ND-YAG or YAG, can be a dye, ruby, and it could be gas, it could be diode in terms of semiconductor. Okay, so the video shows very well of how the electron get excited, and usually that by means of electrical stimulation or by light, like flash lamp. Okay. So get excited, it go to the next shelf. And as it go to the next shelf, when the energy it was returned, and as it return is photon release. Okay, and as a photon release in the optical resonator, we have this photon travel back and forth between these two mirrors, so that they concentrate the photon, and at the end it released out through the laser output. Okay, so all the laser out there except Fotona, they are analog. That is, they're not digital controlled or computerized, so they're not as stable, they're not as powerful. So that's the advantage of Fotona laser already compared to a lot of others out there. Once the laser, when the energy is been released, what does it do to tissue that it will come into contact with? Right? It can reflect, absorb, scattering, and transmit it. And so the effect out of that depends on the energy level. You can have the energy accumulate enough so that it become ablated, the cell will be destroyed, the protein will destroy, or photothermal, that is enough to make protein transform. And that will, in cases we see for skin rejuvenation, for example, all right, the collagen shrinkage, new cells being formed and made, or in the form of photobiomodulation, it's enough to actually change the cell electrical potential, change the behavior of mitochondria, and then the cell would operate in a much better mode, healthy and lots of energy. And the fourth one that dentists, we don't hear a lot of is photoacoustic. However, that effect we've seen a lot in sweeps, in endodontics, and in skin, we can, and beauty, we will be laser hair removal, pigment removal. And these days, Fotona Star Walker also very unique scar treatment. It breaks the scar down very nicely and simple. So here you see this is actually photoacoustic, but a low level low enough to actually take away the pigment of the hair. So hair bleaching. Okay. And then on the other one, this is photothermal effect. The tissue, the dermis in this particular, absorb the laser energy. It's got heat up to 40 degrees or more. That's when the collagen shrinkage happens. That's when new collagen and new blood vessels form and the skin will improve the quality. In this case, it is photothermolysis, ablation. The energy is high, not big power, and we have it to actually apply the skin. This is skin peel. We've seen this happen in the mouth with your gingivectomy, crown lengthening, be it bone, be it soft tissue. Right? And this is high power, kilowatts of power of photoacoustic. The laser itself doesn't see the epidermis, it actually aims for the blood in the dermis. And with the power to go to actually punch 81 channels through the skin at a time, and that helps to break the scar. And very useful, as my love of doing outside of dentistry is scar revision, especially for cleft lip and palate patient. So there are different kind of laser. If you look at the list, it's just an amazing, it's a jungle. All kind of solid state, gas, liquid. We have two on our hand, and that's enough to do many jobs that will be amazed. And we have more and more application. We share new ideas, new research all the time. In laser dentistry and in aesthetic, why we're choosing these two wavelengths? Because Nd:YAG, the chromophore, that is what is looking for to interact with, would be melanin, hemoglobin, deoxyhemoglobin, and in this case would be a bit of water. Okay, and YAG, it have the highest absorption in water, and some say, oh, that make it very weak. No, it's not true. They have, the company have a unique way of control the pulse duration, the peak power, and therefore it can apply hard and soft tissue very easy with comfort. And yet we don't have heat accumulation in tissues, and therefore the patient heal a lot faster. Okay, compare with YSDG and compare with carbon dioxide, which is in this range. All right. And so I just want to bring it up to your attention. That is our laser 1064 Nd:YAG. Here we have all the chromophore in blood, in pulp tissues, in dermis, because we've got blood in there, and also water. So in the case where you actually, let's say we do a lingual phenectomy, and you got a very fibrous tissue and you do the normal gingival troughing, it's okay. But when you go to a little bit fibrous tissue like operculum, that's been scarred many times, you have a hard time cutting with a diode because there's no, the diode, because of the power generating, it's very low. So therefore, it's half and powerful in cases where you have a lot of subgingival margin where the gum bleed a lot, the diode will give up. Okay. And that's where it can be quite useful because its chromophore is also water. All right, so that's an advantage. In skin itself, because it have both melanin and blood, so therefore we can treat a lot of skin conditions. And so high absorption water, and let's say CO2 here, because it have less water absorption, so therefore it can penetrate a lot deeper, faster, but it distributes a lot of heat to surrounding tissues. So when you need things to coagulate, it can happen real fast. But if you don't want things too hot, it can be very difficult to control. All right, so teeth will be a little bit tough cutting with CO2. With CO2 for aesthetic, that can be dangerous because it can hit too fast, and especially with Asian skin, darker skin type, we can prone to hyperpigmentation and burn. So YAG is a much safer alternative. And we come across this very interesting paper, Kawamura, that compare different kind of laser using 1 watt of power. Okay, and then it will cut through soft tissue and see different kind of laser, different kind of erbium, CO2, diode, Nd:YAG, electro surge, and the scalpel to see what's the tissues, what's happening. They measure the temperature. They look at different stain to actually look at the thermal damage, look at the carbonization, and strictly speaking, we pulse and continuous wave. Pulse is when the laser cut and stop so that it releases a lot of heat. All right, continuous wave to continue going. And for diode, very few out there can actually pulsing. And most of them are a continuous wave. Okay, and when you pulse, you have a cooler tissues. And by look at that, you can see in terms of heat damage, the worst is CO2. All right, the heat penetrate pretty deep. And the zone is going out, diode. Okay, the tissue margins damage. Compare with the scalpel, yes, it's sharp, there's no heat involved. The margins intact. But look at ERYAC. This is Fotona laser with water. Sorry, without water and with water, how clean that is. So that's why when we release a flap using erbium, should use with water as well, because the flap resets very nicely and patient doesn't have a lot of post-op discomfort. And the other erbium, then you can see that they actually a little bit more without water, it char a little bit more, okay, because it's a little bit hotter than ERYAC. Okay, and as you increase the output of diode and Nd:YAG, right, from 1 watt to 2 to 3 to 4, then yes, you can go deeper, but the heat distribution, the coagulate layer, the same, okay? And so for each kind of laser, they have the same kind of the same power. It have the same, it's not same power, sorry, the same laser. No matter how high the watt is, it seem to have the same thickness of thermal damage or coagulation, you put it that way. All right, and for analysis of all matter put together, they find that ERYAC was the closest to scalpel as a control method. I'm putting it here because I know some of you would come across to certain company and have been advised with certain knowledge, and just know the basis correction. It will help you to choose the right laser for what you really need. And also for those that use Fotona, would really appreciate what we have in our hand. The Fotona laser and sleep medicine. Okay. When we go beyond cutting flap, doing small restoration, we need larger spot size. And that's when the unique, even flat top beam profile, where the energy in the center on the outside, the same, is very, very important. Because for a diode, you look at, there's a Gaussian profile. We got hot center, so it's this one. And then, therefore, that we have lack of energy unnecessary on the outside. And so the tissue can get heat up unnecessarily. So that's why it's very important that we have the pleasure of having flat beam profile. And when we go to treat mucosa at the back of the throat, the more even energy, that means that we can have a bit higher fluence to do the job without wanting the patient get burned. It's safer, yeah. And also, we have a safety of working distance, be it 2 or 5 centimeter. Whereas a Gaussian, if we look at the 400 micron fiber at 1 watt, right the tip 100%, they got 796 watt per centimeter square, but 10 mils away, you only got 1.5 mils left. Okay, so this is when our colleague who teaching using our 38 handpiece, for hitting tissue at the back of the throat, I say that would be unpredictable because we're too far away. And from the distance from the incisor to the soft palate, everyone's different. So the energy by the time it reaches there, it's not reliable anymore. Much better off, you better go for the Marco family and the Marco S or Marco M. We can use and heat up the soft palate. And I'm talking about gentle heat. We're not talking about heat burn. Yeah. And another unique thing with Fotona, and that influenced our decision on what to do in the day, is a variable square pulse. What it means is that the time you put your foot on the pedal to the shot being fired to the end of it, the energy is evenly fired. So there is no fluctuation. Okay, there's no hot spot. The beam already been controlled by flat top, and now the pulse itself within the 50 microsecond or 80 microsecond or 500 microsecond or millisecond, you have the energy at a stable level, even from the time it starts to the time it stops. So that is very, very important when we deal with soft tissue, such as the soft palate, in our case, is dentist, intraoral, for lifting, for people involved in aesthetics, or even just doing surgery and soft tissue, doing vestibuloplasty, for example. You want a patient to walk out, come back and say, that's hurt me very little. And that's very, very comfortable. And because of the variable square pulse, the flat top profile, Fotona laser already quite safe for us to do the non-ablative treatment for snoring. Okay. A few other factors influence of the outcome, wavelength, fluence, pulse duration, spot size. That all come into detail when you go for master trainings and things like that. But then one would ask, with an erbium such a shallow wavelength, penetration wavelength, how can you heat it deep? Okay, how can you get the heat going deep? It's too shallow. And the answer is in the technology itself, because yes, depth of penetration of ERYAG is quite shallow compared to 1064, for example. The diode, people say, well, I'm using diode, I will get much better result in terms of snoring than you using an erbium. It could be quite wrong, because I look at a few different technology out there. The whole idea there, they were to create scar and cause stiffness in the soft palate. The whole idea we're using erbium for smooth mode in snore reduction, it returns the tissue to rejuvenated state. We're not causing scar, we're not disable the tissue from function normally, we actually return it to healthy state. And so that's the difference between other laser to heat up to cause injury, and therefore you got the soft tissue stiffen up. And it's not the case here. So how did they make an erbium to be a deep penetration wavelength? Well, they played with the thermal relaxation time. And so whenever you fire a shot, there'll be heat distribution. The surrounding tissue will absorb that, some of that. And if the energy been lost by 50% or more, then it becomes useless. So if you want to go deep, you actually will need to keep firing it. But firing it too much continuously, that's when you heat up the tissue unnecessarily. So what Fotona come up with is every pulse of Fotona smooth within 250 milliseconds. There are 6 bursts of 600 microsecond pulses in there, and in between there were just like, non-shooting time. And that allowed the tissue to cool down. And because let it cool enough to cause damage, but warm enough to keep going in. And so that's how we got Fotona smooth going deep into soft tissue and mucosa. Have a blessing because lots of water. So it can go in and we have less damage. If you use you go from oral mucosa onto skin, we have to reduce the fluent because skin doesn't have water, but not the same as mucosa. And once again, that's why Fotona Smooth is very safe for non-ablative snore reduction treatment. Okay, and in the lab, when they study, they know that with particular Fotona Smooth mode, that every shot here, this is one shot of the smooth mode. And within that, you got 6 of these, 600 microsecond, and there's in between, there's no firing, there's cooling time. And if you're stacking the spot 1, 2, 3, 4 in the same spot, you keep it there, we know that the temperature does reach to 45, 50 Celsius degree. That's when you want it to reach that temperature. Why? Because you want heat shock protein. The tissue recognize the temperature, even for a moment of time, is that to signal cells behavior change. Okay, but the collagen fiber itself pick up that heat and instant shrinkage, and therefore the tissue get firm, tight. It happened right there, and then we see right on the spot. Okay, and so with different study, they compare different pulse duration for Fotona. This is 100, 300, 600, and this is 250 millisecond. So they compare the time lapse And yes, for sure, not only the smooth, the window is going deep, but with time, it maintained that heat much longer than other poles. So in early days when we do Fotona snore reduction treatment, we actually use LP mode, which is 600 microsecond. This is 1,000, sorry. And so now we have all using smooth mode. Okay. And so what happened there? Yes, three different results happen, three outcomes. Indirect triggering, okay, so the superficial layer, the keratinocyte, it got shocked, and there's a communication through different channel, and that would involve the whole cascade from keratinocyte signal to fibroblast to change behavior. All right. And then also the cause of direct thermal injury that end up to inflammatory response. And then we have fibroblasts, extracellular matrix repair. Things are more organized, tighten, thicker. And direct simulation, and then you got the heat shock protein, as I mentioned before. So the three main channels affecting the tissue as you're using this the smooth mode. Okay, you got a different action up the top all the way down, but not just the heat directly down here, but also already keratinocyte already signal fibroblasts for behavior change down here. So that was just a sum of what's just a heat shock protein, the pro-collagen 1 and 3 has been promoted and generated, and with time that will be mature. So in the first 3 weeks, these collagen are very weak, so that's why we prefer not to repeat the session any shorter than 3 weeks. All right, so some had do the NightLase once every 2 weeks. I reckon that's too soon because we damaged our early premature pro-collagen, which is very heat sensitive. All right, so our period of repeat once every 3 weeks. Some would do 3 sessions. I personally do 4. Just make sure the patient get over to the completely regenerative state. And we have new collagen formation, and we've got direct heat shrinkage. That's why if we do, like I myself treat patient for aesthetic under different umbrella as a dermotherapist, we saw the patient walk out with the face really tight, firm, and that because the heat shrinkage happened. Okay. And don't have to know too much about histology. You already can tell the tissues in the window down below is a lot healthier, more organized, robust, thicker, and they all go in the same direction, okay, compared to one up the top. The tissues have more cell layer, the basal layer is thicker because they rejuvenate, and that's all the whole idea of the whole regenerative medicine, rejuvenation is all about getting this cell, the basal cell layer, excited. And that's where all the regeneration is happening. And study way back in 2015 on rat models, we already know in the rat uvula, we already know this tighten, it's lift, and there's no damage to the epithelium. Okay, epidermis, I should say, this epithelium, and there's no, the tissue look quite okay, normal. There are no scar, no hyperinflammation, and so the shrinkage with the inflammation or carbonization or necrosis. So that's a blessing. So in Fotona, we have the option when we do snore reduction, we have fractional or full beam. I personally go fractional because, the modern thinking is less is more. What happened there is when you firing this fractional spot, we really be in between these columns of heat. There will be just normal tissues absorb some of the unwanted heat. And in terms of, skin ablation, if we do fractional, we actually would find the recovery, the healing of the top layer faster. But in this case, we do non-ablative, and so the patient will be more comfortable in the chair, and the outcome of fractional photothermolysis these days is the same outcome, if not better. So I will recommend for you to beginner and do a piece of 4. Full beam have its place. In advanced severe case, we might do it more, but usually even in a patient who can take it, usually the first session I'll do fractional and we'll reassess, but very few time I'm actually use full beam. And for the protocol of now that we have there, that's the old time protocols. I still use it from time to time as an add up at beginning or the end. I find it quite useful to actually brush it across to get the tissue more familiar with the warmth before we're actually stacking up with the smooth mode. Okay, so here you would say pulse repetition in light walker, you can only have 2 hertz. You scan, that means you brush across or you overlap. Okay, so we cover an even area and you change direction as you come back to another pass. Or you can stacking. Okay, so stay in one spot. Then we're just hitting it up like the chart that's showing you 4 to 6 shots per spot. You get to the heat shock protein and get released and the tissue got tightened up. So we've got all the technology sitting there for us to help the patient. And so now we need to understand a little bit more about snoring and obstructive sleep apnea. One snore might not have sleep apnea, and one have sleep apnea might not snore. We know that very well, the relationship. But we know for sure the obstructive sleep apnea is a continuum that has been long happening before. Some happen in childhood, in infant state, they already have sleep apnea, and that today, as we're aware, more and more education, more and more diagnostics tool, we realize that a lot of time a child sitting in front of us desperately need for help because of obstructive airway rather than behavioral issue or some other condition that we're just too quick to put medicated them. So in sleep, we have, cycles of sleep. Each of them between an hour, sometimes 2 hours, but as we get older, the cycle shorter. So in there, we're equally half divided by light sleep. Yeah. And it's one where you start to fall asleep lightly, but you're still very aware of your environment. You go to light sleep. And then the other half share almost equally by deep sleep and REM. So deep sleep is when our body metabolism going, toxins, being taken care of, metabolism, we have too much sugar, too much fat today, too much stress today, these things happening. And REM is brain time. It is when the brain detox itself. And so one way to ask the patient to know if they actually sleep in REM sleep is actually, do you remember your dream and have beautiful dream you can wake up and remember? The many patients say, I don't even dream, or kids have night terror. They have all of that disruption. And so that would be a hint for us to know whether the patient is actually a potential with sleep disorder or not. So when we're looking at, there's many different classification of sleep disorder. For us, what we're looking at is snoring, so it's belonging to, in general, in the sleep-related breathing disorder, including obstructive sleep apnea, as defined by American Academy of Sleep Medicine. Okay, the estimate worldwide, we have about 1 billion of people suffering sleep apnea. Okay, so snoring, AHI over 5, and half of those are actually from the mild going to the moderate range that really, really should have help. But for a dentist, we actually want to help the patient at the time they start to snore, not wait until you actually develop sleep apnea. Before we get into that, we have a lot of neck, shoulder pain, a lot of metabolism issue before can actually collapse into the sleep apnea state, especially, into the moderate state. And it's a big problem, all right. And in 2022, they estimate about half of worldwide people around the world have sleep apnea. Okay, it's not 1 billion, it's a lot more than that. But interestingly enough, we all have similar. One is from the Australian sleep disorder pamphlet, and the other one is the American. The statistics are different. They're different in numbers. And yes, for sure, every country, different diet, culture will have different, but overall, it's all going to cause cardiovascular issue. We're all going to have diabetes, thyroid, obesity, brain fog, unable to think, all sorts of metabolic disorder that coming along with it. And to familiarize ourselves with terminologies that we often use in obstructive sleep apnea, we have apnea is when we have total obstruction of the airway. Hypopnea is partially obstructed. Okay, and AHI that we hear most of the time people or the doctor said, okay, your for sleep test, you have mild, moderate, severe sleep apnea. They often just look at the apnea hypopnea index. Okay, that is number of events per hour of sleep that you partially or totally occluded for 10 seconds or longer. Okay. And so if you look at a 5, they dust off, you don't have problem going home. Even under 15, many doctors say, go home, eat better, and come back to see me when you get worse. For dentists, we already jump up and down at this point at the mild sleep apnea because our 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 aim of game is we on preventative side of things, right? And moderate is between 15 and 30, and beyond that is severe. In my city, if the patient walked in with AHI 55 and above, the driver license will be taken off them, okay, until they get treated better. And respiratory disturbance index is when the snoring that the obstructive that actually cause a brief arousal, whether that be 5 second, 10 second, 20 second, and the oxygen desaturation index is another one. We want both of them will be under 5. So these two together with the AHI will, let's say the patient has AHI 10, yeah. So they're in the mild group. But if the disturbance, the breathing disturbance that actually change in their arousal, that's so much, it could be 15, 20, and I see that very often 30, I would push this mild into at least moderate category because a lot of things that's happening over here. All right. And rarer is a respiratory effect related to arousal. Okay. And so, so these are the common indicator when you look at the sleep report. So we need to be familiar ourselves. All right. So hints through the questionnaire. For myself, I observe a patient walk into the waiting room, sit in the waiting room, or in the chair. It already gives me a lot of hint to ask the question because I've done this long enough. But otherwise, you've got a questionnaire that guided you. All right. Patients sitting yawning. We sit in the traffic. You see lots of people stop at traffic light, yawn, and keep yawning. I thought of myself, if I keep going in the opposite direction to this person, I'll make sure I'll be very far away because I don't know when it's going to plow into you. Okay. Morning headache, wake up, irritated, depression, short-term memory issues. Okay. So we diagnose, actually the true diagnosis is by PSG, all right, polysomnography. And then these days we have the home version, which is more convenient. So I tend to do the home version for patient. If it show high or anything that not added up, I would then request to have the sleep physician looking at. Snore lab app that look like that will be something very useful on the phone to monitor your snore during the treatment, so you know the progress the patient can see for themselves and cooperate with you as well. And after treatment, all of the above to be repeated. And on top of that, we can add from time that you read paper, you see SOS snore outcome, spiral bed partner survey, VAS, always saying there, nasal obstruction, septoplasty effective step 4, measure the nasal obstruction. So all of these, as you come across studies, a lot of these has been mentioned. Many of them don't have everything in it, but there'll be some sort of measurement of success based on this questionnaire and survey, okay, apart from the actually PSG itself. So in the eye of our sleep physician, this is what they're looking at, okay, the 4 traits of someone that suspects someone have obstructive sleep apnea. So the anatomy, they look at the upper airway, be it nasal, pharyngeal, and they often mention the word P-grid, okay, the critical pharyngeal pressure that actually would the airways collapse. The arousal threshold, how often you awake. There will be a certain number for this to look at, but it's too long to look into today. Loop gain, ventilatory system, pharyngeal dilator. For us dentists, these are sitting in front of us every day. Pharyngeal dilator, okay, upper airway size. This will be the jaw, the soft palate, you know, the facial profile, the skeletal class, all of that screaming at us that we just don't know what to look for. The pharyngeal dilator, if you look into the palate, we've got the pharyngeal arch, which is composed of pharyngeal, palatopharyngeal and glossopharyngeal. Okay, so this is the one that collapse. And in male, if you look on CBCT, if the distance from here to is very narrow, that is a very high indicator for sleep apnea. Okay, on top of that, we have the muscle of the tongue. We have the muscle of the soft palate, the uvula, and all of that contribute into that collapse of the airway itself. So with the NightLase, this is what we're aiming for, and also under the tongue and on the side of the tongue as well. The risk factor. So this paper is naming it that the lateral pharyngeal wall, tonsillar enlargement, okay, and also narrowing of the, like I said, the width of the airway is the independent risk factor for men. All right. So when you look at someone on CBCT, very narrow at the bottleneck, the narrowest point of the airway or the pharyngeal airway, and if that's very narrow, this is a sleep apnea patient. Okay, very likely. So family history, the age, the women menopause, okay, lose muscle tone. So majority, the change in hormone, the cortisone, that change behavior. Nasal congestion in my city, it happened right now because of spring. Thyroid, endocrine disorder, it changed our sleep. Post-menopause, the same, overweight. All of these are contributing. Okay, so the risk factor we're looking at. So now we know the list. You can see more patient in front of you in the room. So BMI, okay, is very, very high. This is big risk factor. Okay, neck circumference for women 16 inches, for male would be 17. The slouching posture, the shoulder forward, okay, head forward posture in front of the tip of the shoulder also indicate obstructive airway. Okay, the face, droopy eye, drooping corner of the mouth, the deep nasolabial fold, marionette line, protrusive jaw, the E lines out of whack, Mallampati, everything that we know of in orthodontic, anesthetic, anything unfavorable, that is an undeveloped face and jaw, and then very, very likely have a bone collapsed airway as well. In this case, you see deviated septum, enlarged lower turbinates. You start to see some septal growth in the maxillary sinus itself. And the patient, as they don't have the jaw growing forward, if we measure the C line here, a mu indicator line, if you do orthodontic, you'll be familiar with that. That will be easily 45, if not 50. Yeah, so maxilla is retrusive. And as that happens, the soft tissue drag, and they tend to have the ridge in the nose here. All right. And there's surely this only standing up 3.16 millimeter clearance at the narrowest point. Imagine you're lying down in sleep, that would be obstructive. So most patients like this were in their tummy on the side. They can never sleep on their back. All right, so we need to assess all point of obstruction, be it nasal cavity, the jaw, and the pharyngeal, the adenoid, tonsils as well. And we need collaboration of all kinds of healthcare because we cannot do it alone. Mallampati score on your tongue's out. Okay, from 1 to 4, these patients are very prone to obstructive sleep apnea or snoring. Freeman is when the tongue's in, doing similar tests, and the similar, these are the prone patient. Okay, airway obstruction. The tongue got folded because the jaw is so narrow, low tongue posture. The enlarge of the concha bullosa, okay? The maxillary sinus, a lot of time it has septal growth, it got thickening mucosal lining, fat deposit in neck and tongue, the soft palate, okay. It's often is quite red for patient who's snoring. Tongue position, mouth breather, tongue tie. These days, we're very aware of that. Maxillary arch, if you can put a cotton roll up in here and it fit that jaw somewhat okay, but if it's struggle to fit the width, very, very narrow jaw. So that's mean it not NightLase alone. You also need mandibular advancement splint. You need tongue tie to look at tongue exercise and all sorts of things. These are the other tests. If you are interested in these, let me know. If you already know that, to assess someone tongue tie. Okay, and because if the tongue got anchored down, no matter what you do in the soft palate, there's still not enough room for air to come through naturally. And we know that when patients with the thyromental line, the more obtuse they are, the higher risk they have sleep apnea. Okay, for obvious reason, underdeveloped jaw. And also because of obstructive airway, they can't sleep well. They don't burn energy in sleep. They put on weight very easily. and therefore they can having obstructive sleep apnea. So in today's approach for sleep apnea, we have CPAP as number one golden treatment, hypoglossal nerve stimulation, surgery, orthodontic, and advanced mandibular advancement splint with partially or total remove of the soft palate, which I'm totally against, myofunctional, and also dieting. Very, very important here. With the light walker, we can help with tongue-tie release, we can help with NightLase, we can help with photobiomodulation, regain function of the soft palate, and also for healing, for pain relief, because often they go hand in hand with TMD. Okay, we mentioned that slide, Marco family. We use them to heat up for even heat. And so we get to show you that different technique. This is brushing, where you paint across the tissue. And we just overlap into the hard palate a little bit. And then we change direction going vertical. Usually about 7 or 8 passes per area. And this is stacking, where you hold the laser at the spot for between 4 to 6 shots per spot. That's just to help the tissue penetrate a lot. The heat penetrate tissues a lot deeper. And then there was some promote for NDJAC is what I'm talking about, using the Marco, because it's not having a hot spot. It doesn't hurt the teeth, and it's more tolerable. And from where you are, doesn't matter how big, how tall a person is, the energy from the tip of your from the tip of your handpiece to the soft tissue are the same, okay, because of the flat top profile. And for people with nasal congestion, you can do photobiomodulation from outside for sinus, for nasal cavity, or you can go a little bit warmer into the turbinate to encourage more blood flow, all right, to relieve congestion. Again, you can paint on the outside, you can go inside, and these are the protocol. You covered the pharyngeal dilator, the soft palate, okay, the soft palate uvula, the posterior arch here on the side of the tongue, okay. Turbinate reduction, we have these 2 paper has shown with imaging afterwards in this one, that to show the actual shrinkage of the turbinates after the treatment. For this one, we through questionnaire and study and follow-up. Okay. And so if you go to Fotona.com, available on public domain, there are study available. If you're curious and want to know more, for our rep, a very useful, a dentist who want to give information to patient take home, compendium of the clinical study. These are the ones that I got out a good paper for you to look at and to give patient to go home to read. And so that study was in there I was talking about. The leads, when they show the before after the NightLase, has shown the opening of the pharyngeal airway. Okay. Another study, a good 40 patient, younger, okay, and they have moderate BMI less than 30, and the Epworth sleepiness score, sleeping bed partner score, Snoring outcome survey, the VAS, they all have improved, okay. And that also case selection, because lots of things bring on these snores too. Diet is the big thing for patient who's on a lot of sugar, things that promote inflammation, smoking, stress, all of that. We will struggle to get these patients home, and sometimes other factors that come into as well. But if you choose a patient right and do the initial test correctly, that you can show that the results there. There will be the meta-analysis of very big group study, and they got added up the 7 study that come up to the standard total 247 patient follow-up right through. And at the time, the study is a bit older when we still use a lot more of LP mode rather than smooth, but it already show that we have very slight effect. The patient feedback is good, but there's still not enough study of these papers tend to not doing a follow-up sleep screening or sleep study to show the significant improvement. I do that for my patient, but that would be something that need to better follow up on in terms of us as teacher, as researcher, to show what actually worked. The study has shown here also 85% very satisfied with the result. So that's why a lot of our ENT colleague and sleep physician has said we need to show more result to show AHI and RDI. And with Harvey Schiffman in here, it has shown, and this is a study where actually show that, okay, 29 patients in multi-center, and this is a study where they involve both erbium and Nd:YAG. The BMI in the range of 20 to 40, AHI is rather high. It's a mix of forward kind of patient from mild to moderate to severe, but the results are really spectacular. 80% severe to moderate. Okay, 80% of these patients in this treatment, 10% severe to mild. Sorry, this is the improvement of the result. 80% from severe, they move down into the moderate, and 10% severe into mild. One was severe, remained severe, but the overall 45% AHI, that is really good to me. Okay, if you've got a AHI of 100 down to 50, that is amazing. Okay, 50% moderate into mild, less than 5 once they're moderate. So overall, 75% have 78 have reduced more than 50% of outcome. All right, 74 reduction of AHI to below 20. So this is to say that we do it right. It worked really well. Okay, so I won't go into technique because we're not doing a course on that, but just introductory. But there are slight different technique. The different people in the forum that can help you with, and we ask questions and lots of paper to read. Another paper showed case where they actually track it with the Snore lab, and this is the full beam, handpiece. And for my case with Margaret, her AHI, she wasn't really narrow. Her had TURBT surgery before, and when she say, you have Mallampati, Freeman's actually one already, but she's sitting up in the chair snoring away. And then someone very important in the public service in my city, and she said in business class, she's sitting up, flying 1 hour flying, she was snoring away, she's embarrassed. So she asked, whatever you do, I just want you really wear CPAP at night, and she just want to silence down her snore during her flight. That was the goal. And you go 60, yeah. Respiratory disturbance, 60. Oxygen desat, 49 times per hour. And desat between 90 to 96% is 283. So the number is very high. This is severe sleep apnea. Okay. And after we treated her, yes, the number dropped down to half. So she's still high, but now she got a CPAP. And then she would just switch off during flight. Okay. And so that was a goal achieved in her case. And we monitor with the Snore lab, and with time we track the results, and that's what happened. The snore, you're going to retreat and it's silent off, and it come back a little bit more, and it'll come back on, you retreat. So every time the overall line is going down with less. Okay, with Greg, we're nearly there. And with Greg, he presented first time with lots of fractured teeth, vertical fracture line, natural teeth, broken fillings. And he said that I never had not a broken filling in my mouth. There's always something happening. And so and we see in a person, the head upward posture, there's no chin here. Yeah. And the eyebrow, of course, he's older, but you look at the head posture, it's just like someone leaned the head back in order to breathe. And so we're looking at the airway initially, it's only 3 mils. Okay, it's actually 3 by 20. And by the time we treated him, he's opened up much better. Okay, much better. And because we had done implants and many crowns and things for him, so we insist that he will need to wear a guard. So instead of just wear a normal guard, he make him a somnodent. And because somnodent had helped open the airway further and protecting all of his restorative work, he didn't need another NightLase until about a year ago. And that was so 6, 7 years on. Okay, so that's the initial study. He's in a mild zone, but he brush and grind everything off. And then another study that done a few months later, it's coming down a little bit here. Yeah. So, and so, like I said, we offer NightLase, but we did the NightLase. He did both, but he didn't really until recently. He said, I'm snoring a lot more. And the study then was show he got a little bit more, but nothing that was significant. We treat him NightLase again. That's the second time in 7 years. So I find a combination of NightLase and mandibular advancement spleen do keep the patient airway maintained much better. Okay, so Kylie simply complained of snore, low body mass index, fit person, her condyles all bicking back and trap. Not quite a pain patient. Sagittal airway is a bit narrow, and she just wants her snore to reduce. Turbinate's a little bit larger. We talk about sleep hygiene. Exercise, this is a study, nothing significant show up here, right? Light. And she got there about the right sleep proportion. She got some REM sleep through the night. And so she monitored herself through with the Snore Lab app. We can see this is Malampati with a tongue sticking out, and there's a lift. After 4 treatment, we review 6 weeks later. She's happy, and therefore I didn't see the need to repeat the sleep study again. This patient complained about snoring. Tired, he's a night shift worker from Kenya, and he wanted to improving his wellness when he's awake. And so he's broken sleep, and you look at the nasal cavity, it's all happening here because sagittal airway is very wide, the width also very big. The joint's not impacted, it's all happening here. So it's allergy and could be diet related. So just management this area helps with some laser with the turbinates, and we'll get him home, but not quite free of snore until we had jumped in and do NightLase for the soft palate as well. That's when he completely got better. So it's going there up and down, and we're to the end with tracking. So that was really good result. And that's the same when the Freeman we look at, he got a lift there. This dimple here presented tongue tie. Yeah. So that's something we said to him, we'll come back revisit it. If you're snoring, we'll come back too often. Okay. But Jody will be my last one. She can refer to me because I do Botox, and she is Botox resistant. It's only last 2 weeks, not 2 months, 3 months or more. And she will look tired, a big under eye bag. We did the sleep screen, and sure enough, she have moderate. So she have mild, but this add up to push her into moderate plus all the pain she's been having because she's been compensating for airway. Okay. And so what we do is we see how we go with NightLase first because she's rather resistant to appliances in the mouth. That's why she went to Botox in the first place. She's in very light sleep, not enough REM and deep. And so with NightLase, so this is her Bruxa. Okay, very prominent gonal notch, deep, condyle. Her airway was into 6.68. All right. And the width is there, but you look at again the inclination of the central incisors is very steep. So these patients got mandible trap, and it's trap, it caused TMD. All right, that alone is already keep her, restless at night, and she can be very tired. But snore is also a combination, and we also found that she got sleep apnea. So what we do the NightLase sign is all congested here, all fluids in there. Okay, and we know that the condyle is pushed back into the posterior wall of retro distal tissues. And after NightLase, it go from 6 to 10. Yeah, 6 something into 10. The more width happening, but her headache's still there. And so we will propose to do mandibular advancement spleen. And so that was after NightLase, clear. And the night way after NightLase, and we had done with the Somnodent, so it's opened up a little bit further on a different dimension. And now she's out of headache because her condyle's been free. So the dimension of her airways has been improving. Okay, a little bit later, but much, much more. And so by volume, you do the 3D slide. This is by z-axis. This is before 37,000 millimeter cube to 40,000. So when we airflow is to the power 4, so we have a big improvement there. All right, and so for that, I thank you for your attention. And I just sort of snippets into what we can offer. Of course, there's more technique diagnosis if you're very unfamiliar with sleep, with TMD. There's a lot more we can help. You can come over to me in Australia, or in Europe, you can catch me there. Canada, that's where I teach, and maybe some point we will be in Bangkok, hopefully. But that's my contact, and you're definitely welcome to reach out to me, ask lots of questions. And I find our colleagues in Asia are super polite. You don't ask question enough, and you go home with lots of questions. So do ask, and you feel like the question maybe you want in private. I'm there. I can email, organize, WhatsApp, chat. Probably the best way to get in touch with me too.
Dr. Lin, but before we leave, there are several questions right now. Can you please go into Q&A?
Mm. Okay. So the first one for NightLase, how many target total energy can accept more fluent to achieve less total laser shot, but when to get the equal? Okay, it's very hard to aim a total energy, but rather shot per spot to cover the area, because as you know, the study already know that if we stack 4 to 6 shot per spot, you get to that heat shock protein and you heat the tissue enough. And like on average, for a small person, uh, you say 7,000-8,000 shot in total, because the light worker have a way for you to calculate, to document your number of shot. And so 7,000-8,000 is plenty for a small person. I just had a guy nearly 7 foot came into my practice from country town. 16,000 shots later, we're still not there yet, And so it's very hard to say the total energy, but rather the fluence and the number of shots. And then with light worker, typically between 8 and 9 joule per centimeter square is the fluence to go to, and you aim number of shots. So if you go 4 shot per spot, that is stacks 4, you need to do about 6 pass roughly. And with that kind of energy, so And if you do, you can manage 6, and I prefer 6 stack 4 passes, because you can stack more heat if you can stay longer, if patient can tolerate that. Then I would do 6 stack, that means 6 shot per spot, and then do 4 passes. And so if you go to full and too high, patient very uncomfortable. The patient should not really jump about when you're in the chair doing that.
Yeah.
Thailand, the technical, they recommend only yak smooth mode. How different outcome we use ND-YAG, piano, or FRAC 3? Yes, the component of ND-YAG, I personally don't believe it is for heating to rejuvenate. We're using that more so in the effect of healing, or promote healing. And so we do know that it's not about structural, it's about function. And with the soft palate, acupuncture would tell you that too, in the posterior wall of the soft palate of the pharyngeal wall as well. A very important, energy channel there. So by warming it up, you actually get the change of behavior, the trigeminal complex in there does influence the parasympathetic nervous system. And so for that reason, so if you use piano, yes, you definitely can. I probably would go that over FRAC 3, because FRAC 3 doesn't penetrate as deep. So piano is better. Yeah. Okay. But if you stay with yak alone, it's more than enough, because plenty of study only so far, only Dr. Harvey Schiffman promote ND-YAG. But ND-YAG for many of us will be more so, more or less loosely speaking, it's a PBM effect. Okay, photobiomodulation, promote healing. Okay. So improvement of NightLase, the best is in Malampati class. Sorry, I have problem understand this one. How improvement of NightLase for best in ideal in any class improvement or just ideal best for average improvement. Okay. When I think I understand that you looking at NightLase and the lift of the soft palate is judged by the success of your treatment. Is that right? Is that what you're asking? I hope that's what you're saying. Not all patients have a major lift of what you've seen. What you've seen in forums, in Facebook, that's some of the very best case, and some patients don't have as much, but they got very good result in terms of sleep study. And some of them, I reckon, they can actually lift vertically, but a lot of them actually lift posteriorly. So you don't see physical, but you look down or you do treatment, you actually feel you can reach to the soft palate. Dr. Dan maybe can fill me in for that if you agree with that. That the first visit we might struggle to get the soft palate, but as the soft palate start to lift and function better, you feel that you can get easier down to the end of that very end border of the uvula and soft palate itself. And that because that itself, it has tighten and lift, so we can find it's a bit easier. So don't get disappointed if you don't see that. Okay, it's more so the patient's symptom, the questionnaire. And if you can do the sleep screen again, that'll be perfect. Or the Snoring app is also another way of assessing your success. How long does it last? Okay, very much depends on how the patient is. If you live in a totally dusty environment, Asia is very polluted, there's a way around it by sinus wash. Okay, saline sinus wash. As soon as you get home, do that before you go to bed, do it before you get out of house and start about your day. That helps a big deal. If someone have on a high sugar diet, even our diet, even chicken these days, make it to the list of pro-inflammatory food. Thing that promote stress, that affecting your gut will affecting your soft palate, will affecting your sleep and your snore. So you got to control the allergies, control the diet, not be just control what you eat, the quantity. I'm talking about things that pro-inflammations, dairy, wheat in Western countries is the number one cause of problem. The moment we turn away from that, certainly you snore less already. So that is, I do have this long talk with patient, prepare them before treatment to understand, because it's very similar to you treating a gum disease, periodontal treatment. You don't go do all the clean, the patient go home, don't brush their teeth, don't contribute, and they expect result, right? They not got to do it on their end. But sometimes it's hard to ask a tired patient to exercise. They can't until they can have more energy. And so just that's why the CBCT helpful in terms of looking at the nasal cavity, looking at, if the jaw is trapped, they're in the sympathetic mode all the time in their sleep. You need to also make them a tiny little mandibular advancement splint, something that guide the jaw forward, even just ever so slightly in their sleep, that already better. And I find a patient like those patients, if they do somnodent on top of NightLase, they don't seem to come back. They don't seem to snore. And partly, yes, the somnodents open up the airway better. It contribute, but also as the patients snore less likely to relapse, and then they stay longer, So, but I would say to patient, I would go by what you need. You can monitor yourself. It's no lab app. It's your family telling to you. But I haven't really got anyone come back to me sooner than a year. But I've got colleagues have said that they have patients that actually only last about 9 months. If their lifestyle or they have very high body mass index, then it's very hard to actually get those results sustained if the patient is not prepared to put up the hard work with us. Okay. So either studied using laser reduction of the tongue and tightening of the tongue. No, reduction of tongue as you mean like they do radio frequency diathermy and tongue reduction in ENT. I'm not sure what you mean by that. The tongue actually only tightening, the tongue toning, tongue exercise, myotherapy. These days you can do those things online. There's a lot of myotherapists or in Australia that I know of. If you need to ask somebody, they can guide, because you can do that online. You don't have to be in the same country to do that. So tongue exercise, but the tongue be free. So there will be assessment for tongue tie. And then they have to do the exercise first, know what they're supposed to do, then tongue tie release. And once the tongue more toned, then you will snore less for sure.
I think for this question, it means when you use the cycle of the laser at the side of the tongue and when you
Beside the
do,
tongue.
yeah.
Yeah, no, they doing that, but to be honest, there will be no study. There's no data, there's no imaging to say that you help. However, then yes, the group of us who doing so-called functional airway do think that it's more to do with improvement because you got to do with all of the trigeminal, innervation of the tongue to function better rather than you shrinking anything. Because to actually the tongue have a lot of fat in it. When we put on weight, the tongue also put on weight. And so if you want to actually shrink fat in the tongue, it's impossible to do because with what we have, it's not deep enough, it's not far enough, long enough to actually melting fat. So it's not about toning. I think it's more so just for the tongue functions better. Okay, in your practice, you send patient to get slips to report before treatment AVK. Yes, I do. I usually, because I have my own device and very comfortable in interpreting them. And so unless that something doesn't add up or very high, then I would ask the patient to go and see a sleep physician. How many sessions for any Malampati class recommend you send a patient to get sleep report? How many sessions? Um, do you mean like what kind of malampati to tell you how many sessions we need to do? Is that, am I understand you correctly? You can speak. We we're typing, yeah. I'll come to the next one. I'll come back to you, JK. Now, was orthodontic treatment be offered as an option to the last patient? Did you think she benefit more having her upper teeth? Yes, definitely. That's in our whole discussion. So my whole thing is, the whole thing. And I would very prepared that adult would say no to me. Usually those in pain would want to say yes because they had enough. But this lady obviously still don't want things in her mouth. That's why she had Botox and that's why she preferred NightLase before she have the splint. But definitely I'll discuss it all the time because that I believe that it is a true way to get a patient out of there. Right? And they also got fuller face and more aesthetic. That's what I'm after, more aesthetic, healthy patient. Using laser, is that follow up on anonymous attendee?
I think for JK, the session I think maybe about in each class of Malapati, is there any recommend for like how many session for each kind of the class?
No, no, it's we're looking at rejuvenate tissues and overall because we all have different. Because if you have a very undeveloped jaws, I don't expect you're gonna have Malampati 4 go to 1, because the vertical dimension is not the same.
Hmm.
There'll be some lift, and like I said, sometime, and that we're looking at the vertical lift there. And I said, a lot of time, my patient, it looks like it can lift back. You can see further into their throat, further back in, but they're actually not going up. And they already snore less and breathe better and sleep better. So don't get disappointed if you don't see that happen. It's more so the patient. So for the patient, the Snore Lab app is something that they will be very happy with to monitor themselves. And I ask them to let's start do at least 1 or 2 weeks to have a baseline before your treatment so and you can track. And when the one that really actively track, they can see the result and they're encouraged to come back. Because sometimes you say, oh, my wife said I'm still snoring. But when you look at the snore lab, it actually not as much. So that's very hard for someone sleeping next to you, sleeping deeper than you and tell you actually still snore. It's not going to be accurate for the whole night.
Yeah. Okay. Is there any more questions?
So have you all So you can type my answer. Do you have the laser yet of some sort or light walker? Are you looking at one? How are we going there? Because usually I often say to my colleagues, if you look and get a light walker, also you need to prepare your time for learning and training. Yeah. Because it's so many applications. You pay, it sounds like you pay a lot, but actually you pay less. If you add all those applications per different laser out there doing one or two job, you got a quite a cheap laser sit in front of you, very reliable, and make life a lot more enjoyable for us to work. But we will prepare to learn. And not all of us will use everything. Like Dr. Dan was doing crown lengthening and veneer removal because his clientele is in that direction. For me, it would be sleep, TMD, pain. I do a lot of endodontics. Always love doing that. Never liked perio, but drag into it and happy doing that because good result I've seen. Yeah, and so um, and aesthetic, of course, that would be
Yeah.
something that. Yeah.
Okay, last questions. How many sessions should we plan for OSA treatment?
Yeah. The recommendation by Fotona is 3 session, repeated interval between 2 and 3 weeks. I would quote my patient 4 because in the past when I do that, I find the one that going for 4 actually get onto the complete recover side better. Some 3 make it, some residual, and then at 4th session, um, then they're better. So I tell everyone prepare every 3. I can delay the treatment, but if you want to start this treatment, you need to be in town for me because my patients fly all over different state to work. They're in the capital city. You have to be at home and see me once every 3 weeks for 4 treatments. Then we start because if you do 1 treatment, you disappear for 6 weeks, come back. We have 3, and it's not going to be consistent result because I want to make the most of that collagen shrinkage and rejuvenate at the right time. And usually 4, that's all you need. Okay, you're interested in dental sleep medicine, not purchase device. Yeah, yeah. I mean, why not doing that? And as you sitting through the class and doing that, you would find that, and that's what I did for years. I did that 5, 6 years before I came across the conference when I saw the live walker demo doing NightLase, and I think this is what I need. All right, and that's what I buy it right away just to do NightLase and facial aesthetic. That's all I bought it for. Didn't want to know anything else, and not prepared to learn anything else. And I was very wrong. But now I said everything I've done, the only thing I haven't done is gum depigmentation.
Why
Okay,
not?
because my patient wouldn't let me. I begged them, doing free. No, it's not the kind of town the patient's concerned of that. I have very few, Middle Eastern or Indian or inpatient with pigment anyway. And so, but those I found, no, not interested. So that's the one thing that I'm itching to do, but haven't got a case. But we talked about it, got some few cases through plenty of classes. That's the one thing I haven't got personal experience. Okay, do you have photo compare before after treatment in every Malampati? That's what class is the most successful? No, I don't. Like I said, I believe in everyone respond differently to treatment. Like that lady, with that lift there, it wasn't her post-op, it was her pre-op. That lady that got AHI, that one that's snoring, sitting up in business class, right? She have Malampati 1, very big and high. We don't know why her snore, her turbinates look good, or maybe it's just the function of the soft palate that wasn't the best, right? And so, no, I don't. And stuff like I said, it's very unpredictable in terms of Malampati class improvement. There will be improvement, but maybe at most I have seen maybe 1 or 2 cases from 4 to 1, but not the common, you know, 4 into 2, I've seen that, but not all the way to the lift. So, like I said, a lot of people said, "Oh, I'm disappointed. I don't see any of that." No, it's not the only gate of success.
Hmm. So I think there are still more questions. So if anyone who interested in um, laser or in other things about the dental, I think Lin is the best teacher who masters and love all about these techniques. So please follow her. And then she has also the email and the Facebook. We can all reply and then ask for more questions, right? Okay, so I think for today, it's the end of the session, and then next week there will be more about the aesthetic part.
Thank you.
Okay, so we'll see you later.
Okay, thank you. Hope to see you again because of a different topic again. There'll be, yeah. Okay, thank you all.
ครับ
Thank you, Dr. Dan.
Thank
Thank
you
you
ขอบคุณ
everyone.
คุณหมอแดน
Sana
กับดรลินนะคะ
ครับ สวัสดีทุกคนครับ
Thank you.
ทางบริษัทขออนุญาตประชาสัมพันธ์งานครั้งต่อไปนะคะ โดยเราจะจัดเว็บวินาร์ในหัวข้อ Fotona NightWalker Aesthetic Application in Modern Dentistry ค่ะ ซึ่งจะจัดขึ้นในวันอังคารที่ 14 ตุลาคม เวลา 16 นาฬิกา โดยทุกท่านสามารถลงทะเบียนเข้าร่วมงานตั้งแต่ตอนนี้ได้เลยนะคะ โดยสแกน QR Code ที่ปรากฏอยู่บนหน้าจอนี้ค่ะ สุดท้ายนี้ดิฉันในนามตัวแทนของบริษัทเดเซอร์เอนจิเนียร์ขอขอบพระคุณดรลินและทันตแพทย์สันติราชที่ให้เกียรติมาให้ความรู้กับเราในวันนี้ค่ะ On behalf of Laser Engineer team, we would like to thank you Dr. Lin for sharing information and experience of laser snoring treatment with us. And also thank
Thank
you Dr. Daniel, who is one of our Fotona Dental Expert Thailand to be our moderator today. Finally, thank you very much for all to attend this webinar. We hope to see you again in upcoming program. Thank you so much.
Thank you.